So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together. Welcome back, everybody, to the second episode on OCD with John Abramowitz. He is a OCD extraordinaire. We just finished our episode on what is OCD, how to assess OCD. Now we're going to get into a little bit more technical nitty-gritty here about treatment, what makes treatment effective, if there's any new advancements that you think people should know in the literature. So why don't we jump into that part first? Is there anything new in the research world that you think people should look into, either to be informed or to be looking out for, that might be coming out in the future?
Yeah, great question. Since COVID and this kind of shift to doing a lot more mental health care online, there have been a great many studies looking at the efficacy of doing treatment for OCD, primarily exposure and response prevention, ACT, acceptance and commitment therapy, on online platforms using Zoom, things like that. And a lot of this work shows that it works pretty well, that you can get just as good results on Zoom as you can in person. Now, I don't believe that that's the case for everybody. I think, in these studies, you take, like 50 people get randomly assigned to Zoom, 50 people randomly assigned to in person. And so you get the averages of folks, and they seem to be about the same. In real life, though, I think in my own experience, there are definitely some people that, like, we started doing Zoom therapy and just realized, no, we need to meet in person. I need to really be there to coach the person. And then there are other folks that are like, yeah, we can meet over Zoom. I'm afraid of my own bathroom. So instead of, you driving to my house, which is 60 miles away, how about if I just bring my phone or the computer in the bathroom, and you can coach me touching the floor or the toilet or something like that. And that has worked wonders. So I think, for some folks, Zoom is great. For other folks, they need in person. Other folks, it's just a great tool that you can use. I think the research is bearing that out. And then the other thing, it can take a while for advances in the field to catch on, but we're looking at different ways to do exposure therapy, whether that's by adding ACT techniques, like some of the metaphors from ACT. Maybe we'll get into talking about that later. Or using kind of optimizing inhibitory learning during exposure. So a lot of people still think that when you do exposure therapy, you're going to touch the doorknob, and then you're just going to, sit there and wait for the anxiety to come down. And it turns out that, while that's not unhelpful, and we've used that for 50 years and people get better from exposure and response prevention overall, it's the best treatment we have for OCD. But it's probably the case that we don't have to rely on that habituation of anxiety all the time. You don't just sit there and wait for the anxiety to go down. You might get more bang for your buck if the person ties their exposures to valued activities. So I'm going to go touch the door, and then I'm going to read or do my work or something like that. And I'm going to think about my prediction about, is it coming true that I get sick versus not, right? And thinking about what you're learning from the exposure rather than just waiting for the anxiety to go down.
How long ago did inhibitory learning, the model, come onto the market? Like, when did people start talking about that versus habituation?
Yeah, well, the first papers came out in the early 2000s, so it's been about 20 years. But Michelle Krask, who really took it to the next level and wrote a paper in 2008 and then another one in 2014. Michelle Krask and her colleagues, I should say, they kind of outlined, like, what are some of the problems with the habituation model, and what does optimizing inhibitory learning get you, and what are some of the techniques that you can use to optimize inhibitory learning. And so now folks are doing research to investigate this. And I'll be honest, and I'll say that the results are all over the place. Sometimes people find that inhibitory learning based exposure works better than regular old habituation exposure. But a lot of the studies actually don't support that. And I think what's going on is that exposure is so strong, it's so effective. Probably how you do it doesn't make as big of a difference as that you're doing exposure therapy.
I mean, we often think about like different learning channels, like human beings are complex beings. I mean, so are dogs. I mean, they have multiple learning channels and gorillas. It's not just humans. But might it be that multiple learning channels are being tapped through exposure, and habituation is one pathway, and then learning is another pathway? I'm sure there's a lot of other pathways that are going on, and so each one has its utility on a different neurological pathway of getting there.
Probably, the brain is this big black box, and we don't really understand it very well, not nearly as much as some people think that we understand it. So I don't know. I don't think we really understand exactly what's going on in the brain. But yeah, I think you're right. There are different ways that you can learn how to be not afraid. The best way to activate any of those is by experience. Experience is simply the best teacher. You cannot talk someone out of OCD. They have to experience the things that they're afraid of and not doing the rituals in order to get that learning that I'm okay. I can manage anxiety. I can manage intrusive thoughts. I can manage uncertainty or disgust or, whatever emotion is there. There's just, that's just what it takes. And whatever neural process that activates, that's how we learn.
Mm-hmm. Yeah. Just going back to what you were saying before with the research studies and the laws of average.
Yeah.
Well, when you look at the chart, I mean, you have the average and then you have like the standard deviations going out, and you see a range, say, on the chart that's above and below whatever. So that means that you have some people that are hyper responders and some people that are the opposite, low responders in both sides.
Yeah.
Because we're looking at the laws of average, if one's better, you would imagine the whole shuffle would go up and down. But just because something on average works better doesn't mean that a hyper responder in a something that was above average than the other group doesn't mean that they wouldn't have benefited more from the other treatment. Sorry, I said that backwards. A low responder in one that was a superior treatment might be a hyper responder in the other one, and it would be better for them.
Yeah, exactly.
Does that make sense?
Absolutely. Yeah. In both, when you randomly assign people to different groups, you're counting on, in those groups, some people are going to do well, some people are not, but you're looking at the average. And, we can have debates, and people do have debates on how important are the results of those kinds of studies? How important are they to the next patient that walks in your office? And some people say not at all. And other people say they're the most important thing. And the answer is probably somewhere in the middle.
Mm-hmm.
Because not everybody who receives exposure therapy gets better, even though that treatment works for like 60 to 70% of people.
And so I think that's a great example. So you have meds versus like an SSRI medication, so let's get SSRI medication versus doing CBT therapy or exposure response prevention inhibitory. And then you see that they both are equivocal, let's say.
Right.
Well, there might have been somebody that was in the exposure group that had a poor response, and had they been in the med group, they would have had a high response. And so the individual difference is not picked up by the averages. And so I think that's something really important to know, because we'll tout, exposure has been found to be just as effective as medication, or sometimes found to be better than medication on average.
Right. On average. Yep.
Not for every single person.
Not at all. Not at all.
So I know it sounds funny to say that 20 years ago, because I was like, I was like a teenager, right? But 20 years ago in research is kind of recent. I mean, research takes a while. What is it, like 15 years for like it to actually get into the pipeline
Something
of
like
thinking?
That.
And so when we talk about recent advancements and you hear someone say, 20 years ago, we started talking about X, Y, and Z, that actually is pretty recent. There's a lot of people. I was trained on habituation
So
model, and this was like I don't know, like 10 years ago.
Yeah. I still give workshops and people are like, how long do we wait for the suds to come down before the exposure is over? And, we're past that. We don't worry about that anymore, because if the person's suds don't come down, they're still learning something really important. I can get through the anxiety. I can manage the anxiety. And in fact, sometimes we worry that if people become too dependent on their suds coming down, then they learn that the treatment only works if they're not anxious. And we're actually reinforcing the wrong thing. We're reinforcing escape from anxiety. And some people will end up using exposure therapy as a ritual to try to reduce their anxiety, rather than, I can lean into this and I can experience this. And if I'm anxious, that's okay. If I don't get anxious, that's great. But even if I still am, then I can manage with anxiety.
Yeah, so let's get more into what is the efficacious treatment for OCD, and let's hold medication off. And I know neither of us are med experts, but I do think it would be a disservice not to discuss meds in some capacity.
Sure. Yeah.
So we've been talking about habituation and inhibitory learning. We're having a nice conversation, but some people might be sitting here and going, "What is inhibitory learning, or what is habituation?" So, what is the difference between the two approaches, and what do we know about them?
Okay, so let's start with exposure therapy. So exposure therapy is a technique that involves helping the person with OCD to face their fear, to confront the thing they're afraid of. Let's just take a really straightforward OCD, example. Person who's afraid of the floor, right? They're afraid because they think there are germs on the floor, they're going to get sick. And then they go and they wash their hands a lot to try to reduce, the chances of getting sick. So, standard treatment for OCD, exposure therapy, is let's touch the floor, let's sit on the floor, let's, eat M&Ms off the floor, whatever, and learn that, and don't wash your hands, right? And learn that you're probably not going to get sick. I say probably because there's always a chance, right? You get hit by a bus on the way to the therapy session, right? Nothing is impossible, right? Everything has some risk, but the risk of getting sick from sitting on the floor is reasonably low. People touch the floor. They sit on the floor all the time. Kids sit on the floor in class, things like that when you're in kindergarten. We pick money off the floor all the time. And so exposure therapy means we're going to do those things. We're not going to wash our hands, and we're going to see what happens. Now, traditionally, and this comes from behavioral traditions from like the 50s and 60s, the idea was, let's sit on the floor. Let's get our hands contaminated. Let's not wash them. And let's just kind of sit there and see what happens to anxiety. And kind of in the background, the hope is like, okay, the anxiety should subside. That distress should come down. How anxious are you? I'm 90. And then 20 minutes later, I'm 50. And then 20 minutes later, I'm 20. And that does happen usually. That actually, habituation, right? It's like you get in the swimming pool and at first it's really cold, right? The water feels cold, but after a while you kind of get used to it and the water hasn't warmed up, but your body has gotten used to the temperature of the water. And it's the same thing. You get used to the situation. The distress starts to subside. That's a natural thing. It usually happens during exposure. That's habituation. And, the idea of this, the habituation or emotional processing theory of exposure is that when you activate the fear, so you make the person have a lot of anxiety, and then you allow that anxiety to come down within the exposure session, and then you practice it on multiple occasions, and across exposure, the person becomes less and less anxious each time, that there is some learning that's taking place. And there indeed is. The person is learning, I don't have to be so afraid in this situation. I'm okay. My anxiety goes down, and, we weaken the fear. And that was kind of the way that we thought about, how exposure worked for a very long time. Kind of, and I'll touch base on that. In the 1980s and 1990s, there was the cognitive revolution in psychology, and people started, I guess, paying more attention to the thinking, the thoughts that create anxiety or the lack thereof, right? So when I'm anxious about sitting on the floor, it's not just a conditioned response, but I'm telling myself something. I'm going to get sick. There are germs on the floor. I can't see them. I'm going to get sick. I need to wash my hands. Otherwise, something bad's going to happen. And so people started to recognize, well, there's a process. When we're doing exposure therapy, people have these predictions about what's going to happen. I'm going to get sick. And when we're doing exposure, they're learning to change their minds. They're having an experience repeatedly where they're sitting on the floor, not washing their hands, and they're not getting sick. And over time, that kind of disconfirms their fear. Well, so Michelle Krask, who's a brilliant researcher at UCLA, she is kind of credited with taking lots of research that was done on human memory and cognition, kind of synthesizing it into this nice little model of how exposure therapy works, aside from habituation. And so she calls it, and the field now calls it, optimizing inhibitory learning. What does that mean? Well, so inhibitory learning is the idea that when you have OCD, right, you have this prediction, floors are dangerous, I'm going to get sick. When you do exposure over and over again and things work out and you're okay, you don't get sick like you thought, or it's not as bad as you thought if you even do get sick, the person has new learning. Floors aren't as dangerous as I thought. Floors are safe. But it's not that the floors are safe replaces or kicks out the old floors are dangerous idea. Those two things are there kind of competing in the person's mind so that the next time the person drops, a $10 bill on the floor, what's going to win? The floors are dangerous, so I shouldn't pick it up, or the floors are safe. Inhibitory learning is just the idea that the new floors are safe learning kind of like inhibits, right? In other words, kind of pushes down the old idea that floors are dangerous. So to optimize inhibitory learning, we can do exposure therapy in a number of different ways that takes us beyond just habituation. And probably the most important way is we're doing what's called expectancy tracking. So instead of asking the person, what's your anxiety level now? And what is it now? And what is it now? And is it going down? What we're doing is we're helping the patient to identify what's your feared outcome and how likely do you think it is? How much do you expect to get sick? And the person says, 90%, right? The first time they do it. And so you're staying in the exposure. And so how we've been on the floor for a half hour. How you doing? I only think it's like 60% likely. Right. And then the next day and the next day and the next day, and they come back but they've practiced and, nothing happened to me. So I've kind of disconfirmed my fear. I think it's like 1% likely. And so that's what we call expectancy tracking. We're keeping track of how much they believe that their fear is going to happen. And it's thought that that's kind of the mechanism where this kind of change is being made that leads to an extinction of anxiety, of obsessional fear. I just gave a really long-winded explanation, but what can I clarify?
No, I think it's a great explanation. If you want nitty-gritty on inhibitory learning, we do have John's past episode. So after this, go listen to that. And I think it's like an hour of just talking about how to do it, what questions to ask, what we're trying to achieve versus not trying to achieve, and things like that. But so like in Beckian cognitive therapy, right, we evaluate people's beliefs and we look at the likelihood that what they're thinking is accurate in order to shift their thinking to have a change, right?
Right.
But you argued before that the only way to treat OCD is for them to do something different. So for the folks that are coming from, say, training in cognitive therapy, they haven't done too much OCD work. Why do we suggest not that model is less effective than maybe doing exposure?
Yeah. Let me say a few things about that. First, I like to say that exposure therapy is the best form of cognitive therapy. What I was just describing, the change in fear expectancy, that's a cognitive change. And it's coming about not by talking about, well, what's the probability and where's the evidence and what would a friend tell you and, all of that. It's coming about by personal experience, by you're actually in there, you're doing almost like an experiment. So cognitive therapy, if you're going to do cognitive therapy for OCD, you definitely want to incorporate behavioral experiments that are like exposure, where they're going in and they're testing out their beliefs. But there's another issue with cognitive therapy, and that is that sometimes patients will hijack that as a ritual, especially people with OCD. They will if you're using those forms with the columns, which are wonderful. I love Beck and Ellis, and cognitive therapy is like one of the greatest inventions in recent mankind history. But for OCD, folks will sometimes use that as an excuse to go and let's look at all the evidence. Let's look at all the websites. Let's ask all the experts, and let's try to find out. And so they hijack what's supposed to be a helpful principle. They hijack that into a ritual. And so that happens more often than we think. Sometimes patients don't even realize they're doing it. Therapists don't realize their patients are doing it. So in recent, decades, we've kind of had folks steer clear of purely cognitive therapy, the verbal cognitive therapy. But if you're doing exposure, like we just talked about, you're doing cognitive therapy. You're just doing it by experience rather than verbally.
Mm-hmm. So would you say that the main concern with just doing cognitive therapy would be converting it into a compulsion? Or do you think that if a patient, say that they don't use it as a compulsion, do you think that there's something unique about OCD that prevents that learning from going to the deep belief system without the behavioral change? Yeah. Compared to maybe a depression or a social anxiety or something like that?
Yeah, I think it's both. Right. With respect to the second part, people who have OCD, they're using cognitive therapy on themselves. Right. Most of them recognize that, hey, this is senseless. Let me try to figure this out. And most people with OCD, if they have friends, family members who care a lick about them, they're getting cognitive therapy from their relatives. This isn't rational, right? Let's look at this together. Come on, be sensible about this. It might not be the most cordial and empathic cognitive therapy, but they're challenged all the time to think differently. And if that worked, we wouldn't have need for, any other therapy. If you could talk someone out of OCD, most people with OCD would have been talked out of it by their relatives who are trying really hard to do that. It's just that's not enough. You have to put yourself in the situation that you're afraid of, that where you think this is like life or death, and you have to see that it's life. Where you think that something bad is going to happen, or where you think you can't manage it. So a lot of folks with OCD, you can't prove if you're going to be saved or go to hell, right? You can't prove if you're really a pedophile. How do you prove that beyond the obvious, which is you haven't molested any kids? But people with OCD, obviously that's not enough. And so they are in a situation where they need to learn how to be able to manage uncertainty, right? And so you can use exposure therapy from an inhibitory learning perspective to test out their expectations. I can't live with uncertainty without doing a ritual for more than 10 minutes or a half hour. And we can help people to disprove that. Okay, so let's think about, molesting a kid. Let's write a story that you molest a child, right? And ordinarily that would make the person want to go and seek reassurance and look up stuff on the internet and do mental rituals. Well, so how long do you think you can go without doing those rituals? Oh, 3 minutes. I can't stand to think about this. I got to get rid of this thought and do rituals and figure it out. Well, let's see if we can go for 5 minutes. Or how about 10 minutes? Oh, you did it for 10 minutes? Let's try 15. Oh, you didn't do a ritual after 15 minutes? Let's try for a half hour. And what you're doing is you're teaching the person to change their expectations about uncertainty. I can manage uncertainty. Uncertainty is not as bad as I thought. Anxiety is not going to kill me. It's not awful. I can manage that. And, inhibitory learning exposure works a lot by distress tolerance, learning I can lean in, I can do this. Whereas with OCD, you want to push that away. I don't think you can get at that through cognitive therapy. Yeah.
So kind of in a nutshell, exposure therapy, whether it's habituation or inhibitory learning, is having people face their fears.
Yeah.
The explanation as to why it's working is a bit different in each one, but I don't think inhibitory learning says like tosses away habituation as much as it's like additive onto understanding what it's doing.
That's right.
But the idea is by facing your fear and doing something different, you could learn about the probability that fear is going to happen, or how terrible it would be if it did happen, and if you could and if you could tolerate that.
The distress associated with it. Yep, that's exactly right.
So there's the principle of, well, actually, before I jump into that,
Yeah.
what? So we do an exposure. The exposure helps reduce the fear, which has the person do less compulsions, maybe during the day. What do we think is but I know both mechanisms are important, but where are we thinking the real juice is coming from? Is it coming from doing the exposure, or is it coming from being less OCD throughout the day because you're feeling less anxious? Or do we not know?
Yeah, I don't think we know. I think it all works together. I think it's like changing the agenda from I got to avoid anxiety and push it away to I'm okay with feeling anxious, and I'm going to even lean into it. I think once a person gets that mindset that, yeah, I can have that second agenda. I can do that. They get, Albert Bandura talked about self-efficacy, and we know that plays a role, right? So there are behavioral changes, there are cognitive changes, there's personality, self-efficacy changes, probably other things that we don't know about. But I think the research pretty much establishes that those three kinds of things, fear extinction, changes in cognition, which are probably one and the same, and then also changes in just self-efficacy and your how you feel about your ability to do it. I think those are all really important. Hard to say, and it's probably different for everybody, right? Why wouldn't it be different? Some people might benefit from this more than, we're all different.
Or some people are having weaknesses in different areas, so we might be bolstering up an area. I think this falls under self-efficacy, but I call it grit.
Yeah.
That when you face your fears and emotional pain over and over again, you get emotional grit. You get tough.
Yeah.
And what is the thing that we say about kids that like a knight isn't brave because they're not scared? It's because they're scared and they fight the dragon anyway.
Yes. Yes.
And don't we want to teach that to all of our kids?
We want to teach that to everybody
too.
Yeah.
To everybody.
Yeah, exactly. And there are clinicians who don't do exposure. You look for other ways to treat, fear-related problems like OCD and phobias and things like that. Oh, we can't do exposure such and such that is going to make them more anxious, or they can't handle their anxiety. And I think that's unfortunate. I think that robs people of learning that they can. Anxiety at its heart is fundamentally, that's your fight or flight response. You need that. That's nothing to be afraid of. And it would be great if we all learned that we didn't have to be afraid of that. Anxiety is safe and manageable, and it's distressing. But like you said, a big part of exposure therapy is teaching people that grit. And it's a shame that there are, there are clinicians who feel like, I can't make a person do exposure. That's somehow unethical or something like that. That's just not true.
I tell people I don't want to help you learn how to cope. I want to help you to learn how to endure.
I love it. Absolutely.
You don't need to cope if you're enduring. Of course, there's times where things are so tough you have to cope. Right. But I'm talking about for the vast majority of the time, we should be enduring, not coping.
Yeah, leaning into it. Absolutely. And it's unpleasant and it's uncomfortable. But who said that life doesn't have, unpleasantness and discomfort? That's a part of life. We want to get better at that. We don't want to get better at escaping or avoiding that.
Yeah. And anxiety is normal. Sadness is normal. Our negative emotions are healthy. They're normal. And this might be jumping off topic a little bit too much, but I feel for a while now, maybe things are getting, but society was teaching the other message. You shouldn't feel anxious. You shouldn't feel depressed. And then people were thinking, if I feel anxious, a normal amount of anxiety, I must be sick.
Yeah.
And now you're anxious that you're anxious. And now it's doubled down and you're over pathologizing rather than teaching people, like teaching kids that, yeah, of course you feel anxious. Well, how do we go through that?
I think that's very true. And I think our society is very much teaching people that with like things like safe spaces, right? If you don't like on our campus, if you don't like a speaker that's coming to campus, you don't have to go to the talk. You can go to you don't have to go to the talk anyway, but you can go to a safe space where we're going to have donuts, I guess, or I don't know what it is, nice soothing music, but like, come on, you want to confront the things that that aren't objectively dangerous, like anxiety, and you want to put yourself in a situation where you can learn, I don't need to always feel safe. There's safety, and then there's real danger, and then there's danger in the form of anxiety that is perceived danger, but not really real. And we don't need to shy away from those things. But I guess, long story short, our society does teach people that they need to try to feel safe and at all times, and stress and anxiety, those are bad things. And I think that that's taken us down a not the right road. Let me just leave it at that.
Uncertainty tolerance versus decatastrophizing. So just to define it real quick, uncertainty tolerance is exactly what it sounds like. How much can you tolerate uncertainty? Decatastrophizing is having someone have a decreased perception of how bad the outcome is going to be, or the probability that, because really bad things can happen, but the idea is that the probability is not very likely.
Right.
And I see them as hinged. You don't need to have certainty if you don't have a negativity bias, meaning if you think the things are going to go right, you don't need a lot of certainty of what's going to happen, because nothing bad's going to happen, right? So if you catastrophize more, your need for certainty goes up because you're terrified of something negative happening. Okay. That being said, there are some OCD practitioners that hound uncertainty tolerance, and that is their mechanism of change. There's other people that really focus on catastrophizing. I know the answer is going to be both. But how do you navigate when you're trying? What makes you decide which one you're going to tap into, and what's the importance of each?
Great question. I think that the patient knows. So let's say, let's take someone who has a pretty common obsession, which is, what if I hit someone with my car and didn't realize? What if I hit a jogger, a pedestrian, with my car, and now they're at home later and they can't sleep because they're thinking about, I passed that jogger and just not sure they were really close to the road, the car, whatever. So some people might say, if you ask them, okay, tell me about this obsession. Tell me about what goes through your mind. What's the worst part? Some people will say, the worst part is just not knowing. And then other people will say, the worst part is that, what if somebody saw me, hit the person, and I left the scene of the accident, and they wrote down my license plate, and it's just a matter of time before the police show up at my door. And those are two different things. And I think that with exposure, you need to map the exposure onto what the person is afraid of. So if you're doing imaginal exposure, some sort of script where they're, imagining this, because that's how you would do an exposure like this, in addition to, driving around pedestrians, of course. But for the first one, where the person is, I don't know if I did it or not, you would want to work that into the script, right? So I'm at home. I just drove home from school or work or whatever, the park. And now somebody was really close to the car, and I'm wondering if I hit them, and I want to figure it out, but I just don't know for sure. And I guess I'll never know. And, and that's going to create a lot of uncertainty. And then we're going to do, exposure therapy to that. In the other case, then that scenario would have, maybe I hit the person, or maybe not even maybe. I hit the person, and now I'm just waiting. The police could show up at any minute. In fact, there's a knock at the door right now, and now I'm getting hauled off to jail, and, all this kind of thing. So it's the patient knows, I think, what's most important. But I think in most cases, there's an element of both. So it never hurts to do both. And again, like we said at the very beginning, of the show, doing exposure at all is what's important. Getting the person to engage with their fear stimulus instead of trying to push it away is better, is what's important. And probably the little, nuances of how you do it, they can make a difference, but in most cases, they're not going to make as big a difference as we sometimes think.
Yeah, because if you, for the example, if you think about like a habituation model of doing it, you have them do the imaginal exposure where they hit somebody and we put the fear consequence, we have them listen to it over and over again. Their subjective units of the stress drop down below a 3. Now they're feeling less anxious. They're feeling more rational. Prefrontal amygdala is calmed down. Prefrontal cortex is allowed to turn on. maybe I should explain that. When the amygdala, the negative emotion center, is turned on, it tends to dampen the prefrontal cortex. There's a feedback loop. So when we could calm down the amygdala, the prefrontal cortex can better activate.
I'll take your word for that.
Yeah, well, that one I've learned from CPT training, cognitive processing therapy training.
Okay.
Afterwards, I could send you some stuff. It actually was really fascinating stuff. So anyway, so now that the person's thinking more rationally, and now they're not feeling as anxious, and so now they're not spinning there and compulsing, and then they move on with their life. But in that, if you go to the learning side of it, they then learned that they didn't need to do all of the compulsion and worrying because their life has then moved on.
Yeah. Yeah.
So just a little going back and forth between how both of them could play. Does that make sense? I mean, this is more your field than your mainstay than mine.
That makes total sense. Again, elements of both. You're probably in good shape if you have elements of both of those. But I listen to, the patient's the expert on their OCD. They know what they're afraid of. They know their rituals. They know what ties their obsessions and their compulsions together, which is really key. The cognitions. And so if you listen to that, you get all sorts of rich information about how to set up your exposures.
Okay, so outside of exposure, what are we looking at that's potentially efficacious here? So you brought up acceptance and commitment therapy or ACT before.
Yeah. People. Go ahead.
No. I was gonna say ACT or anything else that you want to bring up outside of exposure that people should be aware of. Yeah.
So ACT, I think on its own, ACT, which overlaps a lot with cognitive behavior therapy, and it is a cognitive behavior therapy, and I think there's a substantial exposure therapy component to ACT. An ACT therapist might not say that, but they're wanting in ACT, you want people to live according to their values, which means like leaning into their fear, even, and doing things that are important to them despite their fear, right? And that's exposure therapy. We've developed, myself and Mike Tuhig, who's a researcher at Utah State, we developed an ACT-based exposure therapy where you take, some elements of ACT and some elements of exposure and you stir it together and all that. Lo and behold, we found that it was no different than just doing exposure therapy. But again, like we were talking about before, you got the averages, and probably there's some people that would have benefited from the ACT, and probably there's some people who didn't need the ACT. So that's a big one. There's a treatment called inference-based cognitive behavior therapy, which I admittedly am not an expert on. Again, there are a lot of overlaps with cognitive therapy, changing the way that people think about their obsessions, and there are some overlaps with exposure. So again, you're asking people to do certain things, to kind of take a leap based on their logic, based on the information coming through their senses, which again, an ICBT therapist might say, well, that's not exposure, but it's kind of like exposure, just packaged in a different way. Again, I think, and there's some evidence that ACT can be helpful. There's some evidence that ICBT, inference-based behavior therapy, can be helpful. It'd be good to see more, particularly on the inference-based stuff. A lot of the studies are coming from kind of the same group of folks that kind of are big supporters of that treatment. You'd like to see that be studied, around the world in different centers, kind of like the way exposure therapy is, and ACT is becoming more widely studied. But maybe that'll happen, and that's great. And these other therapies can be helpful as well. That's really where we are right now.
And I know you say you're not an expert in it, but I'm actually not clear. What are they actually doing in the inference-based therapy?
My understanding is that the idea is that when people have OCD, they're taking their obsessional thoughts and they're kind of they're using their imagination, right? That obsessions are a product of their imagination, right? I'm imagining that I hit that pedestrian with my car. No evidence that I have through my senses is telling me that I actually hit someone. I didn't feel anything. I didn't hear anyone scream. There's no blood on the car, whatever. So, why don't I just kind of believe that it didn't happen and act accordingly? And in inference-based CBT, from what I understand of it, that they're doing what looks a lot like cognitive therapy, again, repackaged and using probably different terms, which is lovely. But they're helping people to kind of look at the real evidence. Now, again, we've talked about some of the liabilities of doing that. My concern is that people might turn that into doing a ritual. And, but again, and in some conversations that I've had with folks that do this, they will say that you do have to look out for that happening, of course. And, and then once you've established that, your obsession is your imagination and it's different than the senses, and that's been kind of challenged, then you want to act according to the information that's coming through your senses. Well, boy, that sounds a lot like, what we're doing for exposure therapy, again, repackaged. And if you can get someone to do that without, the technical exposure therapy stuff, but they're still facing their fears and not doing their rituals, fantastic. So again, I think there's a lot of overlap between the ICBT, the ACT, and exposure therapy, more than I think the proponents of each of those different therapies might want to say. But again, sometimes it's a turf thing where people have like, I am this kind of therapist and it's different and it's better and all of that. And but again, to a large extent, I think there's a lot of overlaps. And most folks who are trained in these different modalities will say, if they're being honest, they'll say, yeah, there's a lot of overlap. I can use them together. They take different approaches, and the language is different. And that's great, because we all want the same thing, but how we get there might be a little bit different. And if ACT doesn't speak to you, and exposure doesn't speak to you, so maybe the concepts in ICBT speak to you, or the ACT metaphors speak to you, and whatever it takes to help people to learn that they don't have to get stuck being afraid and doing rituals. That's what we're all about.
I interviewed Michael Tompkins, and we have a podcast episode. I love this episode, and he's a transdiagnostic therapy guy. And he said something on that interview that changed the way that I viewed therapy. He said, sometimes we need to talk people into changing their behavior. And sometimes we could get them to just change their behavior. But if we could get them to just change it, let's just do that. And if we can't get them to change it, then maybe we need to do some cognitive intervention in order to get the buy-in, in order to change that behavior. And I really loved when he said that. It was like a light bulb moment for me as a clinician.
Yeah, that makes a lot of sense to me too. Yeah. Michael Tompkins is a smart guy. He knows a lot about this stuff. He's been doing this for a long time.
And one thing that I'll say to clients too is the cognitive work that we could do, think about it as a flashlight facing the darkness. Sometimes we could walk through the darkness alone, and sometimes we need a flashlight to help us walk through it. But the flashlight is not going to brighten the night. Yeah. It might make it just a bit easier to walk through it, with the idea that you'll learn that you don't need that flashlight over time.
Yeah, exactly. And this is in no way meaning to say that cognitive therapy is bad, or inference-based therapy is bad, or ACT therapy is bad. But, just kind of keeping in mind the strengths and limitations, and that sometimes those things can be used. They can be hijacked, as can exposure therapy, by the way, be hijacked into a ritual. People can use exposure to... I worked with someone once years and years ago who, we were doing exposure therapy. And one day he comes in and he says, I was afraid of this. And so I exposed it. He would say, I exposed it. And then I felt better. And, and then I was afraid of this and I exposed it. And then I felt better. And that didn't strike me as the correct use of exposure. And it wasn't. He was using exposure as a ritual, as a way to escape from his anxiety. And, what he needed to learn was, no, exposure is not about escaping. It's about learning I can manage it. I can lean into it. I can, have a healthier relationship to it, even if it doesn't go away. So he wasn't learning anything from the exposure. He was just using it to make the stress go away.
Mm-hmm. And just to clarify, when I think you're narrowly talking about OCD too, when you're talking about the different types of therapy and cognitive therapy being hijacked and not so as a general principle of therapy for all conditions.
Absolutely.
You're talking. Yeah. I just want to make that clear for people.
Oh my! let me just say, cognitive therapy, and the idea that our thoughts largely influence our emotions and our behaviors. That is like, again, I think that's like one of the most single important tenets of modern psychology, mental health, and CBT is, the most effective treatment that we have out there for mental disorders. And it's all based on this idea that we help people to change their thinking, to help them to change their behavior. And, I hold that in extremely high esteem. We just have to be careful in how we implement it.
Mm-hmm.
Yeah.
Okay. So we're going to take a pause. We're going to come back for one more episode where we're going to talk about what does treatment look like when it's over with, considering medication, and then we're going to wrap it up.
Awesome.